Thank you, Dr. Surendra, my dear friend and colleague, for giving that kind introduction. So I've been asked to speak on a topic which is more on a pathological perspective, but as a clinicians, we will be very proximally involved in deciding what assay, how do we use that from lab to the clinic, and that's been the point of discussion as to interpretation of PD-L1, MSI, and TMB in non-small cell lung carcinoma. So I think all of us who are here would probably ask ourselves few questions, and I'm not sure whether I'll be able to answer all of them here. But what if one uses a non-companion assay in a complementary assay? What is the validity and concordance? That is the first question which all of us often ask to ourselves, because typically how it happens in the clinic that we ask for a lung cancer mutation panel plus PD-L1 testing. We do not usually specify as to which platform do we wish or which antibody do we want, because probably type of immunotherapy that we intend might not have been confirmed before we ask for the test. Second question is there a phenotypic drift with disease progression or an impact of chemotherapy? We know that PD-L1 is a very dynamic test, and does a repeat biopsy and retest is required? What are the guidelines? Why does ICI work even in PD-L1 negative non-small cell lung carcinoma and do not work even in a strong PD-L1 positive patients? That's a question which often needs an answer, and we probably don't have an answer. Can we use TMB or MSI alone to decide the treatment plan in an advanced non-small cell lung carcinoma situation? And what's the way forward? What is the ideal or utopian biomarker? And again, a disclaimer that probably I do not have an answer to any of these questions, but these are the main questions that are often asked when we are talking about the predictive biomarker as far as the ICI in a non-small cell lung cancer setting is concerned. So this is just a basic about the biology which drives the immune recognition. And if you could see here, the step 1 and the step 7. Now, these are the two important steps. I'm sorry. These are the two important steps which are important. And the immune recognition and neoantigen presentation is the purview of what we test in TMB and MSI. And immune activation is what we test in PD-L1. And as against a monolithic EGFR mutation or a ROS mutation, where that is the key oncogenic driver event, and it's easy to target those and probably get a good punchy deep response. This is a tumor microenvironment that we are talking about. There's a tumor immunity that we are talking about, and it keeps on changing. And there are a lot of other factors which govern the tumor microenvironment and the immunity in and around the tumor cells. And that's why probably we still don't have a utopian predictive biomarker akin to what EGFR, what ROS, what ALK is for non-small cell lung carcinoma. So this non-driver mutation lung cancers is always a challenge because we simply do not have a great predictive biomarker as far as the treatment decision is concerned. Now, this is the PD1, PD-L1 axis, which is active, and there is an inhibition of inhibition is what we wish to achieve to enhance the immunity in and around the tumor cells to cause apoptosis and necrosis, and that is what the checkpoint inhibitors do. So this is PD1, PD-L1 axis, and when it becomes active, there is a activation of suppressor T cells, which reduces the immunity in and around the tumor microenvironment, and that reduces the immunity in and around the tumor cells to prohibit or promulgate the growth. And this is the basics of the PD-L1 testing for all the audience here who are clinicians, that we are looking at TPS score and the CPS score, and the denominator for both is the same. It's the number of viable tumor cells which are the denominator. In the TPS is the number of positive tumor cells, whereas in the CPS is the number of positive tumor cells as well as the immune cells. And as we will flow down the line, we will realize the different assays and the different complementary companion diagnostics use different cutoffs for these particular levels. As I mentioned to here, the biology is again programmed. PD-L1 axis is very important, and I would not belabor it here. I think all of us know here. But very important alteration, which is important in non-small cell lung carcinoma as far as the PD-L1 is concerned, is that the expression occurs quite disparately compared with other tumor overlaps. So there is a very less overlap between the tumor cells and the immune cells, and there is also a lot of intratumoral heterogeneity as far as the temporal profile of the event is concerned and in the anatomical localization is concerned. So if you could see here in the Poplar phase 2 study, where they deep dived into the level of IC versus TC, and the concordance is quite different in non-small cell lung carcinoma compared with other malignancies. Again, coming back to the basics of PD-L1 testing, we typically look at it as a companion diagnostics, when it is tagged to a particular immunotherapy agent or a complementary test. And broadly, there are 4 antibodies used and 2 platforms which are used. So 4 antibodies being 22C3, which is the one which is commonly used for pembrolizumab, 28-8, SP263 again is the PAN one nowadays, that's the one which is commonly used, and SP142, and there are 2 platforms which are DECO and Ventana. Now this is a 2020 paper which was in Annals of Oncology, where they had detailed about FDA approved immune checkpoint inhibitors and corresponding antibodies for immunohistochemical staining. And if you could see the difference for a pembrolizumab PD1, it was assay was 22C3 and the threshold is 50%, and it's the TPS that we look at. In pembrolizumab 2016, there was amendment. It was 22C3, the threshold came down to 1%. In 2016, it was 5%, and again, the TPS score was something which was studied. Non-small cell lung carcinoma, atezolizumab PD-L1, but they're using SP142 for 142 as the IHC platform, and TC50 or IC10 is the cutoff, where they're using TC and IC both. And for the Nivo and EP PD-L1, it's a 28-8 assay, first-line therapy, where TPS score is something which is being used. So this is how heterogeneous the companion diagnostics are, and it's actually a clinical conundrum as to which one do we use in our clinical practice. And I will probably try to find out some of the answers to the questions that I asked to all of you in the first of my slides. So again, coming to the question whether what is the concordance? If let's say you've used a companion, non-companion diagnostics or a complementary test and used a disparate ICI agent, be happy that the concordance is upwards of 85 to 90%. So even if let's say you're using SP263 and using pembrolizumab as an immunotherapy, your likelihood that you are on a correct biomarker is upwards of 80%. And this was the study which highlighted this particular concept. So the guidelines, again, as I mentioned to you, that there are companion diagnostics assay. For pembrolizumab, it's different. For atezolizumab, it's different. For Nivo-IP, it is different. For durvalumab, it is different. This particular chart again highlights which are the assays which are being used as far as the companion diagnostic assay is concerned, and what is the proportion of cutoff, and whether we are using TPS or a CPS score as far as the PD-L1 positivity is concerned. This is again the concordance concept which I discussed just now before, and you could see here there is a fairly healthy concordance of upwards of 75 to 80% when you are not using a non-companion diagnostic assay. And now we are talking about adjuvant therapy, neoadjuvant therapy in the ICI ecosystem. Then you're probably looking at using PD-L1 assay in those also or no. Though the current trials of durvalumab, which is typically used in stage 3B non-small cell lung carcinoma, does not include PD-L1 as one of the criterion for deciding the treatment decision. So it's quite heterogeneous still. OS benefit for a PD-L1 high subgroup for atezolizumab versus chemotherapy was maintained in both the platforms, 22C3 and SP263, again highlighting the fact that concordance exists, and even if you're not using the companion diagnostics assay, the PD-L1 positivity still could probably help us in making a decision. Now there is a drift by Roche, who are the main key diagnostics in terms of molecular oncology is concerned. They are moving to SP263 as the gold standard assay, and probably most of the further clinical trials will be on SP263 as far as the non-small cell lung carcinoma space is concerned. So the challenges in using PD-L1 as a biomarker, again, small biopsy, PD-L1 expression in tumor samples collected previously, and there is improper fixation that can alter PD-L1 in cytology. Prepared cell blocks could be a challenge. PD-L1 epitope detected by some antibodies are potentially unstable, so we really don't know whether PD-L1 negative is actually a PD-L1 negative or no. And multiple tumor cell types and multiple other non-tumor cell types can express PD-L1, including platelets. So that's again is a challenge when you're using PD-L1 as a biomarker. So this is again the guidelines as far as the non-small cell lung carcinoma is concerned, that adenocarcinoma, and I would probably not allude to details of the therapy because there's a dedicated talk for this. But PD-L1 is the deciding factor as far as the decision making in the frontline therapy of advanced non-small cell lung carcinoma in a non-driver mutation setting is concerned. So PD-L1 more than 1%, first line therapy pembrolizumab with chemotherapy. PD-L1 more than 50%, then probably atezolizumab as a first line monotherapy could be used. These are the current NCCN guidelines. Again, they are dynamic, and what we do in the clinic is quite different than what is there. Just last couple of slides on TMB. Again, TMB is again a marker of a neoantigen which is expressed on the cancer cells, and high TMB levels usually correlate with high neoantigen level. And then again, that was an attractive point. This could be one of the driving or a predictive factor for deciding the use of immunochemotherapy agent, and was heavily studied. But TMB levels are typically high in patients with non-small cell lung carcinoma who are smokers or former smokers, so slightly more in squamous cell carcinoma, and low TMB is more commonly detected in the never smokers. Tissue TMB is associated with atezolizumab efficacy, which was retrospectively analyzed in the second-line non-small cell lung carcinoma studies. But as I could see again down the line as we move, TMB does not identify patients who will respond to chemotherapy. Therefore, TMB has limited value for assessing combination of immunotherapy plus chemotherapy regimen, and that was the result of this keynote study. Again, TMB is also not an ideal immune biomarker, because some patients with low TMB level also respond to immunotherapy, and others with high TMB levels do not respond to immunotherapy. High TMB levels do not correlate with PD-L1 expression, so there is no concordance or overlap between PD-L1 and TMB expression in non-small cell lung carcinoma. So that option of combining A plus B and coming to an ideal scenario doesn't exist, because there is complete discordance between TMB and PD-L1 assay, as has been studied here in this particular cartoon. So TMB, lack of agreement on the definition of a cutoff, lack of standardization of TMB. So guidelines do not recommend to decide about whether to use ICI purely based on the TMB levels before deciding the immunotherapeutic agent in the first line therapy. MSI high and DMR are extremely rare in non-small cell lung carcinoma, so I would not dwell too much into it. So to conclude, PD1, PD-L1 is an imperfect, though most validated biomarker with limitation and evolution. TMB, there is some data to support biological rationale, but has less validation compared with PD-L1. And MSI is a highly uncommon in non-small cell lung carcinoma, and it's very rarely been used as a predictive biomarker for deciding the treatment decision. And with this, I conclude my talk, and thank you for the patient hearing. Thank you.